Hi, I'm Justin Riley. Today on Wisconsin Doctors, the overarching topic is women's health. We'll be on location at Bluff Medical Center to learn a little bit more about infertility, contraception, and abnormal periods. My guests will include Dr. Catherine Lee Hilsinger. Dr. Hilsinger is a gynecology physician and surgeon. Dr. Mike Peck, he's been on the show before. He's also a gynecology physician and surgeon. And Maria Wolf, she's in gynecology and is a women's health nurse practitioner. That's all coming up right here on Wisconsin Doctors at Bluff Medical Center. Stick around. Welcome back to Wisconsin Doctors. We're here on location at Bluff Medical Center in Boston, and today's overarching topic is women's health. And I'm joined by a fabulous panel here today, which includes Dr. Catherine Lee Hilsinger, Dr. Mike Peck, and Maria Wolf. Welcome to the program, guys.
Thank you.
Thanks for having us here. So, Dr. Peck, I'm going to start with you. What are the subtopics of today's overarching topic?
Well, we discussed, and the thing most patients come to see us for are contraception or infertility, anti-contraception, or irregular periods. So we're going to try and cover each of those in the time allotted. And so,
absolutely. And Maria, I'm going to jump over to you now real quick. Can you just briefly touch on the biggest forms of, or the most popular forms of contraception that you talk about with patients?
Sure. There's lots of forms of birth control. Abstinence is the only true way to not become pregnant. There are three very common birth controls. Birth control pill, which is a pill that the woman takes every day. 4th week, they're hormone free. That's when they get their period. There's the birth control patch, Ortho Evra. This is a patch that's placed weekly for 3 consecutive weeks, so 3 patches. 4th week is patch free. That's when they get their period. And then NuvaRing. NuvaRing is a vaginal ring that they place in the vagina once a month or for 3 complete weeks. And the 4th week, they're ring free, and that's when they get their period. Now, regardless, whatever birth control method you choose, you always want to practice safe sex or use a condom to help prevent yourself from contracting an STD.
Absolutely. And Dr. Hilsinger, I'm going to jump over to you really quick here. And could you talk to us about Depo-Provera, Nexplanon, and IUDs?
Sure. Depo-Provera is a shot that is given every 3 months that suppresses the period and is very effective. The next one is Nexplanon, which is a single rod that goes in your non-dominant arm that lasts 3 years. And there's the IUDs, which there's 2 types. There's one that secretes progesterone, and there's one that is copper. They go inside the uterus. The Mirena, which was the first of the progesterone IUDs, lasts 5 years. The Skyla lasts 3 years, which is a smaller progesterone IUD. And then there's the Paragrod, which is a copper IUD that lasts 10 years.
Wow, okay, so there's some options there. I didn't even know some of those existed. That's pretty incredible. Dr. Peck, talk about some other more permanent fixes for birth control.
obviously, once you're certain you don't want to have any more children, you have to be 100% certain, not 99%. The options are for sterilization. My first recommendation is always vasectomy. It's for the guy, and it's safer, it's cheaper, it's done in the doctor's office. So I'm kind of going against business for me, but it's generally in the couple's best interest. The two options for the women are a tubal ligation with the laparoscope, one tube in the belly button, one right at the hairline. Go inside, grab the tubes, put a little clip on them. Right? Or Escher. Escher is a way that you go to the operating room and take a little scope and you come up from below and you put coils inside the fallopian tubes. I used to be, that's a much newer one, and I used to kind of go 50-50 with the laparoscopic or the Escher, but now there's an FDA recall on the Escher because of some problems with it. So now it's, my recommendation would be vasectomy first. If you can't talk your husband into it, then we'll probably go ahead and do the laparoscopic Filshie clips. But you have to understand this is permanent. Once it's done, it's done. You can't change your mind. The chance of a vasectomy failing is about 1.5 per 1,000. Chance of a tubal ligation failing about 2 to 3 per 1,000. So very effective,
Yeah.
very safe, but also very permanent. So you have to be 100% certain.
Yeah, absolutely. So those are some really good, effective ways, though. If you know, like you said, being 100% certain.
That's the way to go. Then
Yeah.
you don't have to worry about taking any drugs, or it's got the lowest failure rate other than maybe the Depo-Provera or the IUD.
Okay. Wow.
And then one other thing, just because a lot of people, and some of the topics we'll discuss later, even though they've had their tubes tied, there's oftentimes we'll use other birth control for the benefits of regulating your periods, etc.
Yeah. There's other benefits of taking birth control medication, as I understand, other than just preventing births and so forth. So great topics. We got to take a short break here, but we'll be right back with more Wisconsin Doctors coming up right after this. Stick around. And welcome back to Wisconsin Doctors. We're here on location at Bluff Medical Center in Boston, and we've been discussing women's health. We've covered contraception, and now we're going to cover infertility. And I want to start with you, Maria. If a couple is having a hard time conceiving or keeping a baby, what are the first steps that they need to take? If they come and see you, what are the first steps that you take?
Okay. Well, first of all, infertility is defined as you don't become pregnant within 1 year of unprotected sex, okay? And usually the problem is 1/3 woman, 1/3 the male, and 1/3 combination between the two. Basically, if you're not having regular periods or releasing an egg each month, you're going to have issues with fertilizing an egg or becoming pregnant, okay? And there's various things that can cause disruption in the ovulation or fertilization with the egg. And there are several medical conditions. So when I sit you down, I'll be looking for certain medical conditions, thyroid condition, a pituitary problem. I'll be looking at your age, your weight. I'll be asking you, do you have any history of any gynecological problems, ovarian cysts, polycystic ovarian syndrome. And so I'll be looking at those things. Do you live healthy? Are you a smoker? Do you use alcohol? All those can impact your ability to conceive. And so therefore, then we look at sometimes an exam as far as looking at the PCOS, for example, so I'm looking for additional hair, maybe nipple discharge and headaches and those sorts of things.
Sure, there could be a variety of different problems. And then Dr. Peck, what are the next steps after that?
Well, the history will kind of maybe give you a direction where to go, but we'll do some labs, and the primary one would be getting the women to start doing a urine LH kit, an ovulation prediction kit. You can buy those over the counter.
Sure.
Because as Maria suggested, you want to find out if the person ovulating or not. And that's a simple at-home test. You may also check prolactin, which is the hormone your brain makes that gives you breast milk, or TSH, your thyroid gland, because if either of those are abnormal, they can make you not ovulate. One of the key things is the semen analysis. That's always one of the first steps because, as Maria said, half of all infertility is related to the male. So that's a simple thing. You want to make sure that's all done correct before you move down further doing the women's workup.
Yeah, absolutely. And Dr. Hilsinger, obviously there's some ways that these types of symptoms and problems can be treated. What are those? What are some of the treatments that are available?
Well, you want to treat the underlying cause. So if it's a male problem, you send them to a urologist who specializes in infertility. Female problems, is it anatomic? Is there a polyp or something inside the cavity that's causing problems in implantation? Is there fibroid tumors or something that's causing lack of the implantation? Is there tubal disease, so the tube and the egg and sperm cannot meet? Things like that. So part of the workup is laparoscopy, hysteroscopy, ultrasound, to see where we're going. And if we basically have good anatomy anatomy that we find that we then try to fix, then we can do something called clomiphene, which is a pill that helps you ovulate. It's not the octagon pill. The octagon pill is actually a shot that's very expensive. This is a pill that has a 10% risk of twins and a 1% or less risk of triplets, so it's not the uber mom shot.
Right.
You can do intrauterine insemination, where we can bypass the cervix and inject sperm right into the uterus, and you can do in vitro fertilization, which has an excellent success rate.
Okay, great. So there's a lot of options. And it sounds to me, we just have a few seconds left, but it sounds to me, you can correct me if I'm wrong, that sometimes it's not just one problem that's causing a couple from, or keeping a couple from conceiving. It's multiple smaller problems that are all kind of adding up.
Correct.
Yeah, absolutely. Well, this has been great information. We got to take a short break here, but when we come back, we're going to talk a little bit about abnormal periods here on today's topic, which is women's health, here on Wisconsin Doctors at Mile Bluff Medical Center. We'll be right back with more Wisconsin Doctors. And welcome back to Wisconsin Doctors. We're here on location at Mile Bluff Medical Center in Mauston, and the overarching topic today has been women's health. And we've been talking a little bit about contraception, infertility, and now we're going to talk a little bit about irregular periods. So I want to start out by talking with Maria. When a patient comes in to see you and they say, I have an irregular period, how do you make the distinction or make the determination whether that's true or not, whether they actually have an irregular period?
Okay. Well, first of all, we sit down and I ask them about their periods, the characteristics of their periods. It's important to distinguish whether or not they're regular. In other words, having regular monthly periods, they're releasing an egg every month, or are they irregular? Meaning, are they coming every other month? Do they come at all? Are they skipping months, etc.? So it's real important that when you're having irregular periods that you have a calendar and that you write down on your calendar when your periods begin, when they end, how heavy are they, how painful are they, and then that kind of dictates where we go from there as far as ordering lab and exam. And typically when there's irregular periods, it's probably more so a hormonal imbalance. There's other causes certainly, like stress. High stress can cause you to lose your periods or your periods to come late. So we're looking at all those various things when I sit a young lady down or a lady down to talk with them about their irregular periods.
Yeah, so it sounds like you're kind of gathering some history, gathering some data as far as what is actually happening, so that you have something documented, something on paper. Dr. Hilsinger, I want to jump over to you real quick here. Once that data has been collected, once the history has been determined on whether the person is having irregular periods or not, what are the treatments that are available? Or what's the next step, I should say?
Well, the next step is to try to figure out why.
Okay.
So are they ovulating? Are they not ovulating? Do they have a thyroid problem? Are they anemic?
Okay.
Are their liver enzymes abnormal that is causing a clotting disorder? Do they have a polyp inside the uterus? Do they have fibroids in the uterus causing irregular bleeding? So we do blood tests to look at clotting things and hormonal things that can cause it. We do an ultrasound to look for thickened lining polyps, fibroids, etc. Do they have ovarian cysts that will show up on ultrasound? We do endometrial biopsy to rule out any kind of pre-malignant situations, and then we can do hysteroscopy in the office, which is a very simple, easy procedure where we can actually look inside and see if there's a polyp or a fibroid in the office. So there's lots of workup. We can find out a lot of information just in the office.
Okay, so step one is getting that data, getting the history of whether the period is irregular or not, and then finding out if it is irregular, what could be the cause of it, and what are some of the problems there. So then, Dr. Peck, I'm going to turn it over to you, and you can talk about treatments a little bit. If once they find out what the cause is, what are the treatments that are available?
As Maria stressed, that we want to find out if it's anovulatory, related to the ovary, not releasing an egg, versus if you have irregular monthly periods, it's more likely related to the uterus. So if it's anovulatory, basically your body's making estrogen, it's not making progesterone. So we need to give you progesterone. And we can either cycle with birth control pills. Makes your periods regular, makes them lighter. Birth control pills are always the safe first choice, unless you're over 35 and a smoker. Most non-smokers can easily take the pill until menopause. Otherwise, we can just cycle with progesterone. Give you progesterone 12 days of the month. It's the hormone your ovaries not making, and that will give you periods nice and regular. Obviously, you're trying to get pregnant and you're not ovulating, we'll give you the clomiphene, and that's the drug that Dr. Hilsinger mentioned that kind of kicks your ovaries into gear and makes you ovulate. Other options are Depo-Provera, which we talked about last talk, and it's very safe, very effective. The longer you're on it, the less likely you have any periods at all. Or the progesterone IUD is a very good choice. It's not going to make your periods regular, but it should make them very light and protect you about any long-term consequences of unopposed estrogen not making progesterone.
Excellent. So a lot of good information there, and this is something that seems like it's pretty treatable. Like most of the issues that come through are pretty treatable. So don't go away. When we come back, we're going to be talking more about women's health here on Wisconsin Doctors. Stick around. Hey folks, welcome back to Wisconsin Doctors. We are here on location at Bluff Medical Center in Boston, and we've been talking about women's health as the overarching topic today, and we just got done talking about folks who may have irregular or lack of a menstrual cycle, and now we're going to talk a little bit about folks who may think that they have a heavy menstrual cycle. So I'm going to start with Maria a little bit. First, can you talk to us, first define what is considered a heavy period, and then what are some of the treatments that are available for people who have heavy periods?
Sure. Heavy period is defined more so as saturating a super pad or tampon within an hour, or passing quarter-size clots. Okay. Many times heavy bleeding can interfere with the quality of life, your work. In that case, this would deserve a workup. Very commonly, the way to treat heavy periods generally is birth control pills. That's probably the most common method and less contraindicated because of the estrogen within that pill. So if you're a woman over 35 smoking, then probably the birth control pill is probably not a good option to treat your heavy periods. But even though, regardless of sterilization, like tubal, Dr. Peck has talked about in the past, or talked about in prior segment, using birth control to, hormones, the pill to control the heavy menses is certainly an option. The Lyseta is another option. It's a non-hormonal option to control heavy bleeding, and it is a pill that you take 3 times a day for 5 days when you're on your heavy period. Depo-Provera injections, those are an injection every 3 months, as Dr. Hilsinger had mentioned in a prior segment, and this would also eventually, after the second, third injection, many women will lose their periods or at the very least become very, very light.
I think it's interesting that you mentioned that there's both hormonal and non-hormonal treatments that are available for women that have heavy periods. So very interesting. Dr. Peck, I know that there's some simple surgical options that are available. Can you talk to us about some of those?
Well, the one non-surgical, the birth control method is the progesterone IUD that we've talked about before. That is approved by the FDA actually for this, and it decreases the amount of periods, the amount of bleeding you have, decreases the amount of cramping you have. And especially for smokers who can't take the birth control pill after 35, it's an excellent, and we're just trying to buy time to get you into menopause.
Sure.
There's another option is if you find an abnormality inside the uterus, as Dr. Hilsinger was saying, a polyp, you can go in and remove that polyp, and by removing that irritation inside the uterus, it could make your periods back to being regular. Or there's an endometrial ablation, going inside and going to the operating room, and you burn off the lining of the uterus. I usually tell patients about 60% of the time you don't have any periods at all. 20% of the times you'll have periods, but big deal, I'm having my periods, not destroying your life.
Right.
But the other 20%, you get back to where you were, and so you probably need some further treatment. And that will lead us into Dr. Hilsinger.
All right, Dr. Hilsinger, can you talk to us about some of the more, the actual more minimally invasive surgical options that are available?
Sure. The surgical options, basically, if you failed all of the above, the next step would be a hysterectomy. So The most common reasons for hysterectomy in the United States are actually heavy bleeding and pelvic pain, but also you can have pelvic prolapse, which is something we haven't talked about with urinary incontinence and just relaxation of the pelvic floor. So if you clump together all of the reasons for hysterectomy, very small percentage are cancer.
Really? That's interesting to know.
Yeah, most of it's quality of life issues for women who have problems with their uterus and heavy bleeding or pain. So 1 out of 4 women in their lifetime will have a hysterectomy.
Wow.
It's very common. In 2010, they did a study where they showed that 54% of them were abdominal, which is a big incision, which is a 2-month recovery, which was a real setback in a woman's quality of life. More recent figures show that to be less, but the minimally invasive hysterectomies are much more user-friendly or women-friendly because you can return to work fairly quickly. The vaginal hysterectomy is the safest and has no incision. There's a total laparoscopic hysterectomy where we do minimally invasive surgery where we take the uterus, either leave the cervix or take the cervix. Laparoscopic assisted vaginal hysterectomy is similar, where we go through tiny little ports and we remove the uterus and cervix from below through the vagina. And then there's a single incision laparoscopy that is becoming somewhat popular. So there's all sorts of minimally invasive procedures, and Dr. Peck and I are both advanced operative laparoscopic surgeons, and we perform those here at Bluff.
Right here at Bluff. That's very cool. That's very cool.
We have excellent staff, excellent team, and we're very happy to be here.
And we're happy. We're always happy to come in and join here and learn. I always learn something new every time I come to Bluff. So thank you thank you so much for the information, and it's been great talking with you. So
Thank you.
that's all the time we have here at Bluff Medical Center, part of Wisconsin Doctors. From all of us here at CW57, we're inviting you to live longer, live better. We'll see you next time.